My patient George was 74 years old, sharp as a tack his whole life, retired engineer, crossword puzzles every morning, never missed a grandchild's birthday. He walked into my clinic one Tuesday in January, and I almost didn't recognize him. Shuffling gait, glassy eyes. His daughter was gripping his arm because he'd already fallen twice in the past month. She handed me his medication list and whispered, "We think it might be early Alzheimer's." It wasn't Alzheimer's, it was a $6 bottle of Benadryl he'd been taking every night for 3 years to help him sleep. Within 6 months of stopping it, carefully, under supervision, George was back doing his crosswords. He told me at his follow-up appointment, "Doc, I thought my mind was just going. I thought that was just aging." He got emotional, so did I. I have been a practicing geriatric physician for 35 years. I have sat across from thousands of patients over 70 and watched the same tragedy repeat itself in different forms. Medications that were appropriate at 55 become quietly dangerous at 75. Drugs you can buy without a prescription at any corner pharmacy are rewiring the brains and damaging the kidneys of older adults every single day. And nobody is connecting the dots because the side effects creep in slowly, masquerade as aging, and rarely come with a warning label that says, "This is the pill doing this to you." Today, I am going to tell you exactly what those medications are, 5 of them. I'm going to explain what they do to the body after 70 in language that is plain and specific. And I'm going to tell you precisely what to bring to your next doctor's appointment to have a productive, informed conversation about your medication list. My name is Dr. Leonard Brooks. I am a board-certified geriatric physician with 35 years of experience treating seniors. I have dedicated this channel to translating the research in geriatric medicine into practical, actionable information for adults over 60 and the people who love them. If that matters to you, please subscribe. New evidence-based content goes up every single week. Let's get into this, because someone watching right now needs to hear it. Before I name these 5 medications, I need to give you a framework, because without it, you might hear these drug names and think, "But my doctor prescribed this. Surely it's fine." Here is what your doctor may not have had time to explain in a 12-minute appointment. The human body processes medication through 2 primary systems, the liver and the kidneys. The liver breaks drugs down. The kidneys filter them out of the bloodstream. Between the ages of 30 and 80, kidney function typically declines by 40 to 50%. Liver metabolism slows by a comparable degree. What this means in practice is that a drug that your body once cleared in 6 hours may now linger for 12 or 18. A dose calibrated for a 55-year-old body can accumulate in a 75-year-old body to levels far beyond what was intended. At the same time, the aging brain becomes dramatically more sensitive to sedative compounds and a class of drugs called anticholinergics, substances that interfere with the neurotransmitter acetylcholine, which your brain uses for memory and learning. The blood-brain barrier becomes more permeable with age. Protective mechanisms wear down. The margin between a therapeutic dose and a harmful one narrows in ways that most standard prescribing guidelines, which are designed around average adults, not older adults, do not adequately account for. This is precisely why the American Geriatrics Society publishes the Beers criteria, a rigorously evidence-reviewed, regularly updated list of medications that are potentially inappropriate for adults over 65. Every medication I am about to discuss appears on that list. This is not fringe medicine. This is the consensus of mainstream geriatric science. Now let's talk about the 5. Medication 1. Benzodiazepines. Xanax, Valium, Ativan, Klonopin. The brand names are probably more familiar to you than the drug class. Xanax, Valium, Ativan, Klonopin. Doctors prescribe benzodiazepines primarily for anxiety and insomnia, and in the short term, they do work. That effectiveness is a large part of why they're so widely used, and a large part of why they are so consistently dangerous for older adults. Here is what happens after 70. Because the liver metabolizes benzodiazepines more slowly, these drugs accumulate in the bloodstream over time. A dose intended to help you fall asleep at 10 p.m. may still be pharmacologically active in your system when your alarm goes off at 6 a.m. or when you get up at 3 a.m. to use the bathroom. You may not feel sedated, you may feel completely awake, but your coordination and reaction time have been quietly compromised. This is how falls happen. And I want to be very direct about what falls mean at this age because I think we have a cultural tendency to minimize them. Falls are the leading cause of fatal injury in adults over 65 in the United States. Not car accidents, not heart events, falls. Multiple systematic reviews have confirmed that benzodiazepine use is associated with a substantially elevated risk of injurious falls in older adults, falls serious enough to require hospitalization. Beyond fall risk, benzodiazepines consistently impair memory, attention, and executive function in people over 70, even when they feel they have adapted to the medication. I hear this often. I've been on it for years. I'm used to it. The research does not support that. Adaptation to the sedation is not the same as neurological protection from it. The entire benzodiazepine class is explicitly listed on the Beers criteria as drugs to avoid in older adults. If you are currently taking Xanax, Ativan, Valium, or Klonopin, I need you to hear this clearly. Do not stop taking it on your own. Abrupt discontinuation of benzodiazepines can cause life-threatening withdrawal, including seizures. This is a conversation to have with your physician about a supervised gradual taper conducted over weeks or months, depending on how long you have been taking it. I'll tell you exactly how to frame that conversation later in this video. I want to hear from you. Comment below right now. Are you or someone in your family currently taking any of the medications I'm naming today? Leave a comment. I read them, and the pattern of responses genuinely informs the topics I cover next. Medication. 2. Diphenhydramine, Benadryl, Zicil, Unisom, Tylenol, PM. This one stops people cold because it costs $60, because it's been in every medicine cabinet in America for decades, because it's sold without a prescription at every pharmacy, every grocery store, every gas station convenience aisle, and it is, in my clinical assessment, one of the most quietly dangerous substances a person over 70 can take regularly. Diphenhydramine, the active ingredient in Benadryl, Zicil, Unisom sleep tabs, and the PM formulations of Tylenol and Advil, is a first-generation antihistamine. It also happens to be one of the most potent anticholinergic drugs available over the counter. Anticholinergic means it blocks acetylcholine, the neurotransmitter your brain depends on for memory consolidation, learning, and cognitive clarity. Let me give you the research in plain language. A landmark prospective cohort study published in JAMA Internal Medicine in 2015 followed 3,434 adults aged 65 and older for more than 7 years. Researchers measured cumulative anticholinergic drug exposure and tracked dementia diagnoses. They found a clear dose-response relationship, meaning the more anticholinergic exposure, the higher the risk. Adults in the highest cumulative exposure category had a 54% increased risk of developing dementia compared to non-users. The most common drugs in the high exposure category? First-generation antihistamines, exactly like diphenhydramine. A 2019 study published in JAMA Internal Medicine, examining nearly 60,000 dementia patients, corroborated those findings. The evidence has continued to accumulate since. Now let me tell you about my patient George, the man I mentioned at the beginning of this video. 3 years of nightly Benadryl, progressive cognitive decline that his family, and for a time even I, initially attributed to early dementia. After a thorough medication review and a careful supervised discontinuation, his cognitive test scores stabilized and then partially improved. He got his crosswords back. George is not unusual. He is representative. If you or a family member is taking diphenhydramine nightly for sleep, that is urgent information to bring to your doctor. There are safer alternatives. I'll address those specifically before this video is over. Medication 3, ibuprofen and naproxen, Advil, Motrin, Aleve. These are the drugs people reach for the moment their knees ache or their lower back flares. They are in every household. They are sold in bulk at warehouse stores. They are, for many older adults, as automatic as morning coffee. And the kidney damage they cause accumulates silently. No symptoms, no warning, until the function is already significantly and sometimes irreversibly reduced. NSAIDs, non-steroidal anti-inflammatory drugs, are filtered from the bloodstream through the kidneys. After 70, kidney function has typically declined by 40 to 50%. When ibuprofen or naproxen circulates in a body with already reduced kidney capacity, it stays in the system longer, reaches higher concentrations, and progressively damages the renal tissue responsible for clearing it. The 2023 update to the American Geriatrics Society Beers criteria specifically reinforced the need for renal function-based assessment before prescribing NSAIDs to older adults, citing the frequency with which this drug class causes acute kidney injury in people over 65. But the kidneys are only part of the story. The stomach lining becomes more vulnerable with age, and NSAIDs directly impair its protective mucosal barrier. According to data from the National Institutes of Health, older adults who use NSAIDs regularly are 3 to 5 times more likely to develop a serious gastrointestinal bleed than younger users taking the same dose. And gastrointestinal bleeds in adults over 70 are significantly more dangerous, slower to detect, harder to manage, more likely to be fatal. For anyone managing cardiovascular disease or hypertension, add a third layer of risk. NSAIDs raise blood pressure and increase fluid retention, which elevates heart failure risk in an already vulnerable population. Daily ibuprofen or naproxen use after 70 is not pain management. It is, without appropriate medical supervision, a slow accumulation of organ damage. And it happens quietly enough that by the time it's noticed, the damage is already substantial. Tell me in the comments, do you currently use ibuprofen or naproxen for joint or back pain? I want to know because the safer alternatives I'm about to recommend apply directly to you, and I'll address them near the end of this video. Medication for zolpidem, Ambien. Roughly 10 million Americans are prescribed zolpidem, sold as Ambien, every year. It is the most commonly prescribed sleep medication in the United States, and the FDA has issued a specific safety communication about its use in older adults that I don't believe enough people have read. Here is what the FDA found. Elderly patients can have blood concentrations of zolpidem the morning after taking it that are far higher than those of younger users who took the same dose. The drug lingers. The body hasn't cleared it by morning, and here is the critical detail. The patient does not feel drugged. They feel awake. They feel like themselves. They make breakfast. They get in the car to drive a grandchild to school. But their coordination and reaction time remain pharmacologically impaired. Research consistently shows that zolpidem use is associated with nearly twice the risk of hip fracture in older adults. I want you to sit with that number, nearly double the risk, from a medication prescribed to help you rest. Hip fractures in adults over 70 carry a 1-year mortality rate of 20 to 30%. That means up to 3 in 10 seniors who break a hip will not survive to the following year, not from the fracture itself necessarily, but from the cascade of complications that follow: blood clots, pneumonia, prolonged immobility, functional decline. A hip fracture at 75 is not like a hip fracture at 45. It can be, and frequently is, a life-altering or life-ending event. There's a second problem with zolpidem that makes it particularly insidious. It suppresses the deep restorative stages of sleep, the stages your brain uses for memory consolidation and cellular repair, while increasing lighter sleep stages. So you fall asleep faster, but you wake up less restored, which drives the urge to take it again at higher doses for longer periods. The medication doesn't actually solve the problem of poor sleep. It shifts the shape of the problem while adding significant risk. If you are currently taking Ambien, this is a conversation to have with your physician. But again, do not stop abruptly. Have a supervised plan. Medication 5. Proton pump inhibitors, PPIs, omeprazole, Prilosec, Nexium, Prevacid. This is the medication that surprises people most. Proton pump inhibitors, omeprazole, Prilosec, Nexium, Prevacid, are among the most prescribed drugs in the world. And for short-term use, 4 to 8 weeks, they are appropriate and effective for acid reflux and stomach ulcers. The research supports that. The problem is that most seniors aren't taking them for 8 weeks. They've been on them for years, sometimes for a decade, without reassessment, without anyone asking, "Do you still need this?" Here's what happens in the body during long-term PPI use. Your stomach acid is essential not just for digestion, but for absorbing critical nutrients from food. Suppress that acid for years, and 2 nutrient deficiencies develop quietly in the background. First, vitamin B12. A study published in JAMA found that long-term PPI use was associated with a 65% higher risk of B12 deficiency. In older adults, B12 deficiency is not a minor nutritional gap. It causes peripheral neuropathy, the tingling, numbness, and burning in the hands and feet that many seniors are told is just aging. It causes cognitive decline that in clinical presentation can be nearly indistinguishable from early dementia. I have seen patients labeled with dementia diagnoses whose primary driver was severe B12 deficiency from a PPI they had been taking for 9 years for an ulcer that resolved in the first 2 months. Second, magnesium. The FDA has issued a specific safety communication warning about hypomagnesemia, dangerously low magnesium levels, in long-term PPI users. Low magnesium affects cardiac rhythm and nerve signaling. In older adults who are already managing heart conditions, that compound risk is not trivial. Let me describe a patient. He had been on omeprazole for 9 years, originally prescribed after an endoscopy confirmed a gastric ulcer. The ulcer healed within 3 months. The prescription was never revisited. By the time I saw him at 76, he had been living with severe numbness in both feet for 3 years, a persistent cognitive fog his family described as being not quite there, and fatigue that had progressively worsened. His B12 came back critically low. His magnesium was borderline. We tapered him off the PPI over 8 weeks, started aggressive B12 replacement, shifted his reflux management, which had become mild and infrequent by that point, to dietary modifications and a lower risk medication when needed. 4 months later, the numbness was clearly improving. His family said the fog was lifting. 9 years. An unnecessary prescription, renewed again and again at annual appointments that never included the question, "Is this still indicated?" One thorough medication review changed everything. I don't want this to be a video that leaves you frightened but uncertain. Fear without direction isn't useful. So here is exactly what to do after you finish watching. Step 1. Write down everything you take, every prescription medication, every over-the-counter drug, every sleep aid, every antacid, every pain reliever, every antihistamine. Benadryl counts, Advil counts, Prilosec counts. Over-the-counter does not mean outside the conversation. It means it requires more vigilance, not less. Step 2. Request a geriatric medication review. Call your physician's office and ask specifically for a comprehensive medication review evaluated against the American Geriatrics Society Beers criteria. Use those exact words, Beers criteria. Any physician who practices in this space will immediately know what you're referring to. If your primary care physician is not familiar, ask for a referral to a geriatrician. You are entitled to that level of care. Step 3. For pain, ask about acetaminophen first. Acetaminophen, Tylenol, is significantly safer for the kidneys and gastrointestinal tract in older adults than NSAIDs when used at the correct dose. For adults over 65, the safe ceiling is 3,000 milligrams per day, not the 4,000 on the package. And that's total across all sources, including combination medications. Ask your doctor whether acetaminophen is appropriate for your specific type of pain. For arthritis in particular, it is frequently sufficient and dramatically safer. Step 4. For sleep, ask for a CBTI referral. Cognitive behavioral therapy for insomnia, CBTI, has been shown in clinical trials to outperform every sleep medication currently available for long-term outcomes. No drug interactions, no dependency, no morning impairment, no fall risk. It typically runs 6 to 8 weekly sessions with a trained therapist or via a structured digital program. The American College of Physicians recommends it as the first-line treatment for chronic insomnia in adults. That is not a fringe recommendation. It is the standard of care. Ask your doctor to refer you. Step 5. For PPIs, ask 2 questions at your next appointment. First, do I still need this? If your reflux is mild or well controlled through diet, the answer may be no. Second, has my B12 level been checked recently? If you've been on a PPI for more than 6 months, a B12 level is a reasonable and important data point. It's a simple blood test. It takes 30 seconds to order. I have to say this clearly before we close because I am a physician and responsible communication requires it. Do not stop any prescription medication without speaking to your doctor first. Benzodiazepine withdrawal without medical supervision can cause seizures. That is not a metaphorical risk. It is a life-threatening one. For anyone managing heart disease, kidney disease, diabetes, or multiple concurrent prescriptions, any medication change, even a seemingly minor one, requires coordinated medical oversight. The goal of this video is not to alarm you into abrupt self-discontinuation. The goal is to give you the information and the language to have a more informed, more productive conversation with your physician. These 5 medications are not universally dangerous in every context for every person. There are cases where they represent the best available option after safer alternatives have been tried and failed. What I am telling you is that in adults over 70 used long-term without periodic reassessment, the research is clear and consistent. The risk profile changes, and many older adults are carrying that risk without knowing it. Your body is different at 70 than it was at 50. Your medication list may not have kept pace with that change. Today is a good day to start that conversation. Leave a comment below with one of 3 things. Comment, "Reviewing my list," if you are going to check your medications after watching this. Comment your age and which of these 5 medications you want to bring up with your doctor. Or comment, "Sharing this," if you're sending this to a parent, spouse, or loved one who needs this information. And please subscribe to this channel if you haven't already. Next week, I'm covering 5 supplement combinations that are quietly dangerous for adults over 65. Including combinations that are being sold together in the same bottle as if they're perfectly safe. Some of what I'll share genuinely surprised me, and I've been in this field for 35 years. That video could matter to someone you love. I'm Dr. Leonard Brooks. I'll see you next week.